So today we'll be talking about how we can help our DC residents navigate medical care here in the district, specifically advising when and how they should go about seeing a medical provider. So our objectives for today, of course, I want us to feel a little bit more comfortable when identifying when we should advise our residents to seek medical care, be able to better differentiate indications for primary, urgent, and emergency care visits, be able to share some reliable, trustworthy health information sources to our residents. Ultimately, this is all so that we can improve our patient advocacy and set some healthy expectations when they seek medical care as well. And lastly, we'll give some tips on how to effectively use medical insurance as well. So, of course, we are all doing this just so that we can help improve health literacy here in the district. But specifically, I do want to highlight the CBA goals of, again, helping our DC residents improve their communication with their health providers, be able to have more informed decision making, and be able to access more appropriate healthcare. So, of course, I am emergency medicine by training, so I always like to briefly discuss the impact on healthcare, specifically in the emergency department. And as we know, patients and residents, when they do not um, appropriately understand their health history or medical conditions, that this unfortunately does have some poor outcomes in health. It also results in significant increase in emergency department utilization. Oftentimes, people are seeking healthcare when their conditions have become more severe, and sometimes irreversible. Is quite sad to see. And we have to acknowledge that our healthcare system is quite convoluted and complicated. And there's so many specialists and different types of health providers and different health institutions. And oftentimes it's overwhelming. And when people become overwhelmed and they don't know where to go, they often end up in an emergency department. And while the emergency department is a great resource that is happy to assess and treat and try to triage concerns and um, suggest where people should go for follow-up, we do have to acknowledge that it's not always the most efficient way that residents could be spending their time or seeking medical care, and it does result in significant increase in healthcare costs as well. So before we dive in, I wanted to go over a few patient scenarios just to see what can result when patients don't have um, a great understanding of their health history. And you'll see that there's some key buzzwords that I want to highlight later on, and those should kind of like clue us in as professionals when we should advise our DC residents to seek care and what type of care. Okay. Oops, what have I done here? Okay, so scenario one, a 40-year-old patient is brought to the emergency department by her partner with a complaint of intermittent confusion, severe vomiting, abdominal pain, and labored bleeding. She is unable to eat or drink anything without vomiting profusely. The patient tells you that she was recently told that she had a sugar problem by an ER doctor when she was living in Florida and was prescribed 30 days of medicine. However, she finished all of her medications when she moved to DC 2 months ago. She doesn't know the name of her medications, what they were for, if she was supposed to stay on the medications long term. Her blood sugar is measured and the result reads high. You ask her if she's seen an endocrinologist. A what? She responds. And I just want to poll everyone here and see what are some things that you're picking up from this scenario that could be improved upon. And again, it's hard to tell exactly where that lapse of communication um, occurred, but of course, we want to ensure that we are setting up our patients and DC residents with the most knowledge to the best of our abilities. So this is an example I like to highlight, especially when I'm teaching my residents or my med students in regards to the importance of talking about what is the diagnosis today, both using the technical term and then also using a layman's term as well. Like, I'm concerned you may have diabetes. That is a problem with your blood sugar. But I'm also like a huge proponent of writing stuff down, whether that's the provider writing that for the patient, but also encouraging the patient to write down what's being shared with them in their own terms as well, just to help that be more readily understood in the future. And the other thing I would like to point out as well is that it sounds like it wasn't clear that this patient was supposed to be on medication long term. And again, trying to figure out where that lapse of communication occurred. But again, making sure that our patients or our residents have great instructions written down as well as verbal, and just having that follow-up and in play where I'm going to give you 30 days of medication right now, but I really want you to see a doctor so that they can keep this medication going, and that ideally want you to be on medication long term. Thank you guys for your participation. So moving on to our next scenario here. So this is a 20-year-old female with no past medical history who comes to the emergency department with complaints of a sore throat and a cough for one day. She denies any difficulty breathing, chest pain, or shortness of breath, and she's still able to drink fluids and eat soft solids. She is unsure of what she can take to alleviate her symptoms, and she has not tried any pain medications. She read on social media that her symptoms could be consistent with a viral infection, and she's requesting thorough testing. At her request, a full respiratory vital panel is done in the ED. Unfortunately, her vital signs and physical exam are within normal limits, and she's safely discharged home with anticipatory guidance, return precautions, and instructions on how to use over-the-counter medication to alleviate her discomfort. Later, she is shocked to receive a bill for $683. Is there anything that you notice in this scenario that we can improve upon? So we are going to talk about using our resources more efficiently and cost effectively as well. And also just, again, kind of going back to expectations is also just knowing, while sometimes we can have symptoms that are uncomfortable, just knowing when to seek care as well. She had symptoms for one day, and I know it could be a little bit miserable, but again, trying to triage when it's appropriate to wait for primary care, urgent care, or going straight to the emergency department. Okay, so a poll for you all. When you suggest that an individual seeks medical care, sees a health provider, do you usually instruct them where to go? And if so, how do you decide between a clinic or primary care versus urgent care versus emergency department? Yes. And so I will keep going here. So again, as you highlighted, I'm really hoping that this presentation can help increase comfort in guiding DC residents on how to not only access care, but being able to differentiate where to go. And I want to acknowledge that this presentation won't be exhaustive of all the indications that one type of care versus another, but I do hope that this helps establish a stepping stone and also helps us be more comfortable when talking about these reliable resources that can help guide our decision-making process. So of course, I always like to ask 3 basic questions. If you ever feel like you are at imminent threat of harm, you feel that something is life-threatening, that is a hard stop. That is when you go to the emergency department or you call 911. Then conversely, we think about, I'm uncomfortable, I'm not feeling well, but I don't feel like I'm at imminent risk. I don't feel like I'm going to face severe harm or die today. And that's when you could feel like you may talk to your primary care doctor to see if you get an expedited sick patient visit. And that in between is where we talk about urgent care, where, I feel safe, but I am uncomfortable, or I do know that I need to see my doctor sooner rather than later, and I need to see them within the next few hours. And that's when we say, go to urgent care. And whenever in doubt, The other backup mechanisms, sometimes you could call your primary care triage and talk to them. They're often really great at advising you where to go or going to your emergency department. Again, I know that it is sometimes a long wait. I know sometimes daunting, but again, if you are concerned about your safety, we are always happy to see you, assess you, and and make sure that you're stable and direct you to where you need to be. So I wanted to share a few examples of presentations that are appropriate for an urgent care. So this includes your small cuts or lacerations that require stitches or sutures, um, cold and flu symptoms, earache, sore throats, eye discharge or redness. I want to emphasize without vision changes, painful or uncomfortable urination, your aches and pains, minor burns without blisters, insect bites, minor allergic reactions, and minor car accidents. And by minor car accidents, I mean more of like your fender bender accidents where there's no airbags going off or there's no significant intrusion into the cabin of the vehicle that individuals are able to get out the car on their own and they're like relatively low mechanism. Next, talking about the indications for the emergency department. So this is where I really want this hard stop. I'm concerned about you. I want you to go seek care. So chest pain, any kind of difficulty breathing, fainting or losing consciousness, head injuries, especially for our individuals who are on blood thinners, have a history of seizures, have lost consciousness after hitting their head, or have a visible deformity to the skull, or any other severe symptoms, such as a severe headache or vomiting afterwards. Um, Also, any kind of neurologic symptoms, such as focal weakness or numbness or facial droops, sudden onset confusion, or severe dizziness, would also be recommended to go to the ER. Burns with blisters or that are significantly large, I'm going to say large, encompassing an entire limb or encompassing a sensitive area such as your face or genitalia should go to the emergency department. Severe vomiting, and when we say severe, it's often when you're having difficulty eating or drinking or keeping what you ingest down. Vaginal bleeding in pregnancy, black or bloody stools or vomiting, uncontrolled or bizarre bleeding. And by bizarre bleeding, I mean bleeding from places that you shouldn't be. So whether this is a cut that's bleeding profusely, or if this is you're urinating blood, you're coughing up blood, you're bleeding from your eyes, something that is unusual, come to us. Mental health crises, and this is huge. Coming to the emergency department if there's any suicidal thoughts, homicidal thoughts, concerns about auditory or visual hallucinations, or again, exhibiting behavior that's pretty unusual for that individual. And then lastly, sudden onset vision changes. And then our primary care. So I love our primary care clinics and physicians, and they're actually much better equipped in treating chronic issues. And by chronic, I mean symptoms that have been present for 3, 4 weeks or longer. Oftentimes, these are situations where you want to start medication and see how that individual is responding to that medication. So having that longitudinal care and having that same provider being able to reassess and being able to titrate that medication or add and subtract accordingly is going to be in that resident's best interest. And you see that a lot with our mental health complaints such as anxiety or depression, asymptomatic high blood pressure, chronic pain, or chronic coughs as well. And then you'll also see some overlap with some of the urgent care complaints as well. Again, this is kind of trusting your gut and saying like how soon can I see my primary care provider and can I wait? Um, the other symptom I really want to highlight that should trigger a primary care visit is unintentional weight loss. And this is different than dieting or exercising and losing weight. That's great. But if you're like, I am doing absolutely nothing different, but I'm losing 20, 30, 40 pounds over the past like month or two, that's unusual. And is sometimes concerning for an underlying health condition. And we want you to come to your primary care doctor or healthcare provider for screening, blood work, and or imaging. And again, when in doubt, please feel free to use the resources above. And again, it's kind of trusting your gut and saying, can I wait? And can I call and talk to a nurse and have them triage my concerns? They're usually great in saying urgent care, emergency department, or we will see you tomorrow, or coming to the emergency department. One thing I do want to share is that calling 911, especially if you are concerned, can be a great resource. Our paramedics or emergency medicine services can do screening vitals and a screening exam and can consult a doctor over a phone. It does not absolutely necessitate that you have to be transported to a hospital or emergency department. And if you're not transported to the hospital, there's no associated cost. That being said, this is a resource that should not be abused. I say this if you are, again, absolutely concerned about your safety and your well-being, that's when you should call 911 and they will gladly assess you as well. So I want to ask, how can CBOs help improve um, personal and organizational health literacy for our DC residents, especially when it comes to navigating this complex healthcare system? And that is tied in with what I have suggested here. So, of course, we want to try to disseminate health-based information to our DC residents. This could be including, but not limited to, posters, pamphlets. I think the FAST campaign that was really big with stroke awareness is a great example. You saw those pamphlets, those little handouts literally everywhere. And now oftentimes you ask people what FAST is, and a lot of people are actually quite familiar with that strategy. Similarly, this was done with COVID-19, and I really hope that we can maintain that same momentum now that we're no longer in the pandemic and apply that same energy to a lot of our common health conditions that we're seeing out here in the district. Of course, outreach initiatives that allow community members to directly ask professionals advice questions. Sometimes this can be done with, CBOs partnering with some of our academic institutions. Oftentimes you see a ton of people who are glad to volunteer, ranging from attending physicians, residents, nurses, other community health workers. But sometimes that is nice to just have someone to talk to. And also does help build some trust with the healthcare system as well. And then my big plug is helping our residents prepare for medical encounters, which I'm going to talk about a little bit more in just a second. Kind of just giving them a step up of how to communicate their symptoms and advocate for themselves when seeing a health provider. Incorporating more patient advocates and community health workers into organizations. They are an amazing resource that help us navigate an array of health options. And I do think actually private patient advocates with CBOs actually have a unique vantage point over some of the in-house patient advocates that we see at certain hospital systems, just because they're often really knowledgeable of different options that are available across different hospital systems as well. And then again, as I keep mentioning, being able to refer reliable health information sources. And then I wanted to dive into, how do you help determine a trusted health or source of health information? Any suggestions? I'll take one or two. And I think that is an excellent point, having that trust with that institution. One thing that I always like to share, especially for in like this digital age where a lot of people are online searching for information and not knowing what is the best source to listen to. I always like to say, start off with a government health website, and these usually end in .gov, .gov. Examples include our CDC websites that actually have printouts on various health topics, especially cardiovascular disease. Medline Plus is run by the National Library of Medicine, I apologize. And Living Well DC, which is actually a huge project that we're working on, and I want to give an extra plug here. So DC Health is actually actively building this Living Well portal, which will ultimately serve as like this one-stop shop to share some basic health information, such as one-pagers. Currently, there's a one-pager on monkeypox, so please stay tuned for more information about this portal. I think it's really promising. And through Living Well, you can actually access LinkU, which is another DC Health affiliated website. This is more of a resource guide as to where residents can seek care, but also where they can seek social services that help address other health-related social needs. So again, please stay tuned for these two websites as they're actively building up. I do think that they're going to be really promising for our residents. Number two are academic and research institutions. So you'll note that they tend to end in .edu or .org. I put an asterisk at .org because you also see some other people filtering in with .org, but .edu is definitely safe. And when I see academic and research institutions, these are often the universities that we know are associated with like medical schools or hospitals. They often have a lot of ongoing research or public health initiatives. I will state that sometimes they propose treatments that are not quite yet standard of care. So sometimes they do have clinical trials that they may mention, whereas .gov is definitely our standard of care, but both of these together are definitely great resources. And you'll also see that some of our professional organizations, such as the American Heart Association, the American Academy of Pediatrics, they also go by .org. So hearts.org would be the American Heart Association, healthychildren.org would be our Associated with Pediatrics, and those are regularly updated with guidelines as well. This resource is like a little bit more convoluted. Our medical professional websites, they're a great resource, but they tend to be written in more academic framework and can be a little bit harder to comprehend if you don't have that background. They tend to be for those who want a little bit more in-depth information of current policies or statistics or social determinants of health. So, and they tend to mention either peer-reviewed or list citations. And that's what I usually tell people to look out for. Again, this wouldn't be my first stop shot for basic information, but for someone who really wants to go down that deep dive, I think that's a fair source to share as well. And again, being wary of social media and blog posts, we want our residents to understand that some medical conditions have similar presenting symptoms. So just by reading that one person had a similar symptom and was diagnosed with XYZ doesn't necessarily mean it's going to be the same for you. But always taking that information that you see and bringing it to your health provider. I do think it's a great way to have a constructive conversation saying, you know, I read these symptoms and I'm concerned about leukemia, and having your provider say, you know, I think that's a reasonable thing that we should work up given your personal history versus, you know, fortunately, your physical exam and your test results are actually quite reassuring. I'm not concerned for leukemia at this time, but thank you for sharing your concerns, and we'll continue the monitoring moving forward. And then I want to talk about preparing for medical visits. So I this is something that is actually near to my heart as well. I spend a lot of time even coaching my loved ones, my family members, how to kind of start conversations with their health providers when they seek care. I think it's very easy to walk into your healthcare provider's office and like suddenly forget everything that's going on. I feel like it's walking into a grocery store and forgetting what you went in to buy. So I want to talk about the few things that we can suggest that all of our residents know before stepping foot into that provider's office. So 4 things I really encourage our residents to know: their past medical problems, their medications that they've been prescribed or advised to take, their allergies, and their symptoms. And these are some handy tips that I've seen in my personal practice and really appreciated, and ultimately have kind of kept in my back pocket and recommended to, again, my loved ones and my patients alike. So keeping a list of your medications. Some people keep flashcards in their wallets. Sometimes if you were recently in a hospital or a doctor's visit, sometimes those discharge instructions list your current medications and how you should take them. Or if you always get your medication from the same pharmacy, that pharmacy can actually give you a printout of your medication name as well as the doses as well. Or you could call. Health journals are amazing. We've actually made them available through our health literacy curriculum. So again, really making that big plug for our residents to use those journals to document what's going on. Smartphones. So a lot of us are walking around with smartphones. I'm a big proponent of just putting it in that note section in your phone. It's always on you, so you don't forget. And then medication bottles can be helpful. I will say be careful taking your medication bottles like to and fro. I don't want you to lose your valuable medications, because if you lose your medications, sometimes that could be a different battle to have them refilled before they're due for refill. But if you have an empty bottle or empty label or an old label, bringing that to your visit can be helpful as well. Documenting your past allergic reactions, not just to what, but what exactly happened. Did you develop a rash? Did you develop difficulty breathing? Or did it just make you nauseous? Um, and then journaling your symptoms. So practicing describing what you're feeling. Is it burning? Is it sharp? Is it achy? What makes it worse? How often does it happen? And kind of documenting those triggers for it too. Like, I notice my stomach hurts after I eat, but I notice it feels better after I go to the bathroom. Or I notice my head hurts when I wake up in the morning, but it's better after I eat breakfast. Just those tips to help inform your provider on what tests are indicated as well. And then these are the questions that I really encourage patients to ask providers. This is a two-way street. So I want them to feel comfortable with the care that they're receiving, and don't shy away from asking what this test is for, when I can expect the results, how do I spell that medication, and are there any side effects? Will it interact with what I'm already taking? And then why do I need this treatment? That's a huge one. Um, what are the alternatives? What are the complications? And then what is the best test or treatment for my needs? Is this indicated, or is this something that you could go without? And how common is this procedure? And then again, setting the expectations when our residency health providers. Again, we acknowledge that the healthcare system is convoluted. It is not always the most efficient. And sometimes seeing your provider is not going to result in a immediate resolution of your symptoms. But it's often setting the stage of, I'm concerned about you. I think you should go to the emergency department. They'll do a screening examination. If you're safe to go home, they may send you home, but you may have to go see your primary care doctor for further tests, opposed to, I am uncomfortable now. I want all of my relief or all of my symptoms to immediately dissipate. But also on the two-way street, knowing what to ask for, and knowing that, I am presenting for care. I do expect some kind of workup or assessment to, again, alleviate my concerns as well. And then lastly, navigating healthcare costs and insurance. So unfortunately, this is a huge source of stress and hesitancy to seek medical care. So 41% of adult Americans are currently facing healthcare debt, and 46% of adults actually skip or delay medical care just because of the cost alone. We know that 1 in 10 adults in the US have significant medical debt. So we can't talk about accessing care without talking about how to access affordable care. The one positive thing is that a lot of residents in DC actually do have medical insurance or qualify for health insurance, but unfortunately, a lot of residents don't know how to use it. So we'll talk about that in just a moment. So we actually have the second lowest uninsured rate in the US, right behind Massachusetts. So in 2018, as the rate of those going without health insurance was increasing, we were decreasing, and we came down to 3.2. So I'm really optimistic that the statistic can be used in our favor, that with this coverage, we can hopefully get more residents into more consistent medical care. And then this is just a brief reminder of our DC Healthy Families, reminding ourselves of the eligibility criteria for our DC residents to qualify for Medicaid for your low-cost health insurance. I will also include that newborns, children with disabilities or special needs, and people living with HIV/AIDS are also included as well. So I have insurance. Now what? So step one is to call your insurance company, call the number on the back of the card on the website and ask what locations or facilities are within network. What is covered? What is the cost of this treatment or this test? Also work with your healthcare providers, share your concerns saying, I'm not positive this test or treatment is going to be covered. Oftentimes there are things that we can substitute in that place, which are equally effective, or choosing medications such as generic medications over brand name medications that are making sure that they're more affordable for our residents as well. And also asking it for patient advocates as well. And again, I think this is another thing that we can really focus on in regards to improving that health-based information that we're sharing with our DC residents. The language and terminology that's used with medical insurance is confusing. So again, reminding ourselves and familiarizing our residents as well, just exactly what these terms mean so that when they do have medical insurance, that they can make informed decisions that are, again, hopefully more affordable for them as well. Lastly, I always say, let's talk about our options. So if a resident is visiting a health provider and it's suggested that they undergo some special test or procedure, what are the options if it is quite expensive, even with medical insurance? Oftentimes, you can work with case managers to make payment plans. Sometimes, depending on the individual and their insurance coverage, sometimes that payment plan can actually be a little bit lower if they're paying out of pocket, opposed to going through insurance. So again, kind of comparing their options there. You can also call your insurance company and negotiate prices at times, or with the health institution themselves. Sometimes health institutions, especially our academic centers, tend to have some amount of money that they're willing to have patients apply for, and they grant more so on like a need-based scenario. You can also appeal your insurance decisions. I've done this many times for myself, for loved ones. And this also works with working with your healthcare provider, saying, you know, it was recommended, this was an indicated test, this should be covered. And again, does this always work? It may not always work, but it doesn't hurt to ask. And so I always say, try. And then lastly, working with our patient advocates or our community health workers, they are an invaluable resource, often at no cost to our residents. They've actually done research that showed healthcare systems save $2.20 for every $1 invested in a CHW. They decrease ED visits, they decrease hospitalization rates by almost 13%. They save hundreds of thousands of dollars annually. So they are an amazing, amazing resource to have our DC residents talk to. And lastly, I just want to have a summary of some actionable items for our CBOs. Again, I hope that this presentation was helpful in suggesting when we should have our residents seek medical care, and also triaging that medical care and being able to kind of direct where they should go in regards to primary, urgent, or emergent care. I hope that we feel a little bit more equipped with skills and tips to navigate these patient encounters, and that we can also help set some expectations for our DC residents as well. I hope that we also feel a little bit more comfortable recognizing reputable sources of health information and sharing that with our patrons, and educating on how to use medical insurance as well. And lastly, I hope that we are able to use our patient advocates and our community health workers to our advantage and advise our DC residents appropriately so that they can navigate this complex healthcare system. So, of course, I have some references here. I'm happy to answer any questions or concerns or take any comments at this time. But thank you so much for your attention. I really appreciate it.